Welcome to the Sudanese Orthopedic Surgeons Association, SOSA presents Extracapsular Fractures of the Proximal Femur webinar.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين. معكم دكتور معاذ مصطفى، استشاري جراحة العظام والمفاصل. Welcome everybody. Today we're gonna talk about anatomy and biomechanics that related to extracapsular femoral fracture. All we know that intracapsular femoral fracture is one of the most common fracture, which represent of 50% of hip fracture, common in the elderly population, especially elderly female with osteoporosis that fall down on the ground level. By the end of this talk, I'm expecting the audience that be able to understand the bony anatomy that define extracapsular region and the critical osseous petrous, the calcar femoral, and the lateral wall, and the trabecular mapping that dictate physiological stress trajectories, and also muscle vectors that responsible about fracture displacement. Finally, the biomechanical stress transfer across the proximal femur. To understand the intertrochanteric fracture or distinguish intracapsular from extracapsular fracture, we must know the anatomy of the capsule, which is attached anteriorly to the intertrochanteric region and posteriorly 1 centimeter proximal to intertrochanteric crest. Which enforced by ligaments, iliofemoral ligaments and pubofemoral ligaments anteriorly, and ischiofemoral ligaments from posterior. All the neck is laid inside the capsule, the intertrochanteric region that lies immediately outside the capsule. Therefore, the extracapsular fracture involve bone distal to the intertrochanteric line or crest. The bony architecture of the proximal femur consists of 4 regions. First, the femoral head, which is a spherical part that articulating with the acetabulum, and the neck is a cylindrical part that lie inside the capsule, and intertrochanteric region from the greater trochanter to the lesser trochanter, and subtrochanteric region, which is lie 5 centimeters below the lesser trochanter. What is the petrous of the intertrochanteric region? We have medial and lateral petrous. The medial petrous consists of calcar femoral, which is the most critical anatomical structure for biomechanical stability. It located medially, which is a vertical blade of bone extended from the posterior medial femoral shaft upward to the posterior aspect of the femoral neck. Histologically, it's a condensed cortical bone, not like surrounding trabeculae. It's far thicker than it. About the role or anatomical role of the medial calcar, it acts as a primary medial column of the proximal femur. The biomechanical role, it's a primary pathway for transferring compressive load of the femoral head to the femoral shaft. So the fracture of the calcar disrupts this mechanism and lose its medial support that convert the compression force to the bending force. The other petrous here is the lateral petrous, which consists of the lateral femoral cortex, which is the thick cortical bone of the lateral aspect of the proximal femur, extended from the vastus ridge proximally to the base of the GT. The biomechanical role of the lateral wall is act as a lateral tension strut. During weight bearing, the lateral cortex resists tensile forces generated by bending movement of the femoral neck. Anatomically, it prevents proximal fragment from displace laterally and prevent also external rotation. Okay, what about the trabecular architecture of the femur. The proximal femur is consists of a system of trabeculae, which is honeycomb appearance of a crossing trabeculae according to the stress trajectories and wall flow. There is two systems. There is a medial compressive system, which is vertical arching from the medial shaft of the calcar radiating upward to the femoral head, which consists of primary and secondary trabeculae, compressive trabeculae, I mean. The lateral or tensile system, which oblique laterally from the lateral shaft cross to the neck to superior femoral head, which also consists of primary and secondary trabeculae. There is another group of trabeculae in the GT, and also crossing of compressive and tensile system, leaving a triangle which is called Ward's triangle, which is the weakest point. What's the biomechanical rule of this system? This trabeculae is not a random. It represents flight pathway of the force transmission. Any interruption of this line causes stress shielding. The proximal femur is functioned biomechanically as a cantilever beam. The femoral head is represent the fulcrum where the load is applied, which is represent body weight. And the femoral neck represent the lever arm, and the femoral shaft, which represent the fixed point. During the bending moment happen when the body weight acting on the head create a massive bending moment across the intertrochanteric region. Compression occurs in the medial concave side that resisted by calcar, and the tension occurs in the lateral convex side that resisted by the lateral wall. In the extracapsular fracture, this bending moment is the primary driver of implant failure or fracture displacement. The fracture displacement is dictated by unopposed pull of all muscles acting around the proximal femur. The gluteus medius, minimus, and tensor fasciae lata acts as abductor that abduct the greater trochanter proximally. And iliopsoas flex and externally rotate the proximal fragment. Short external rotators attached to the posterior femur cause external rotation of the femur. Hip adductors, like adductor magnus, brevis, and longus, that attached to the femoral shaft that act as adductor and shortening of the distal fragment medially and proximally migrate the distal fragment. The net deformity, the proximal fragment goes into flexion, abduction, and external rotation, while the shaft goes in adduction and proximal migration. The configuration of the fracture that dictate the stability of the fracture. The type of, we have two types, either to be stable or unstable. Stable like oblique and transverse fracture, the fracture line runs such that weight-bearing force produce compression force across the fracture site. The bony surface goes in impaction. The other type, like reverse oblique fracture or highly comminuted fracture, the line oriented perpendicular or opposite to the compressive forces. The weight bearing produce shear force. The biomechanical fact of that the shear force is far destructive than the compressive force. It causes proximal fragment to slide laterally and slide and distally relative to the shaft without any bony opposition. What's the role of the calcar in load shearing? In the intact femur, almost 70 to 80% of axial load pass through to the medial cortex and the calcar. In the extracapsular fracture, The calcar is intact. If the calcar is intact, even with a fracture, like in a stable fracture, load is still transferred from the head to the shaft medially. If the calcar is comminuted, there is gap, the medial pathway is lost. So the 100% of load now transferred to the lateral side dramatically, increasing the bending moment across to the lateral cortex that will produce fatigue failure or implant cutout. The role of the lateral wall is to provide also torsional or rotational stability. In intact status, the lateral cortex resists external rotation that generated by short external rotators. In fracture, the lateral wall is compromised, so the fracture is distal to the lateral ridge, vastus ridge. The proximal fragment is free to rotate externally. That change it to rotational instability that convert the hip from uniaxial bearing joint to the multiplanar unstable articulation, where the shear force is maximized. What is the femoral offset? The femoral offset is the distance between the center of the hip and the mechanical axis of the femoral shaft. The biomechanical rule of this offset, the larger the offset, the more efficient abductor moment arm, but also increased bending moment across the intertrochanteric region. In case of the fracture, when the extracapsular fracture occurs, the effective offset increased the proximal fragment collapse into the varus. This varus is further increased the bending moment by creating positive feedback instability and stress on the medial calcar. Okay, now in the end, we take a home message. We have to know that the calcar femoral is the medial compressive strut, primary load pathway. The lateral wall is a lateral tension strut that resisting bending and rotation. Muscle vectors that dictate classic deformity, abduction, flexion, external rotation of the proximal fragment. Fracture orientation that dictates stability of the fracture, either compressive or shearing force. The load of medial support transfer axial forces into the destructive bending force. Thank you very much.